This is David Harden from Minneapolis, Minnesota, and this poster was presented at the ASCRS meeting in May of 2019 using the KeraFlow device in an epithelium on collagen cross-linking system at Minnesota Eye Consultants. The financial disclosures are listed here on this slide. Some background information on collagen cross-linking is that it's used mostly in patients that have progressive keratoconus, but it can also be used for other ectatic conditions such as pellucid marginal degeneration or post-LASIK ectasia. And it's used to stiffen and strengthen the cornea to reduce disease progression, hopefully then being able to keep a patient that's tolerant of glasses or contact lenses in those glasses or contact lenses, and hopefully can avoid keratoplasty, which has a much longer recovery time and a much higher complication rate than collagen cross-linking does. We participated in a variety of different corneal collagen cross-linking trials over the last several years. We participated in the study that led to the approval of the Avedro epithelium off collagen cross-linking protocol, and it achieved approval in 2016. Avedro also has epithelium on cross-linking trials that are currently in progress as of the recording of this video. At Minnesota Eye Consultants, we've been utilizing a modified version of the Avedro protocol where we pre-saturate the cornea with a higher concentration of compounded riboflavin containing a topical anesthetic as well as benzalkonium chloride first, and loading this through the KeraFlow system distributed by ESI. And then we add the approved Photrexa solution to the cornea and utilize the light source that's manufactured by Avedro here for distribution in the United States. And we've done several different trials over the last several years looking at this protocol, and there seems to be a very low risk of postoperative complications such as infection and scarring, because we're able to remove only the superficial epithelium and leave the vast majority of that epithelium intact for those patients. In this slide, we describe the protocol at Minnesota Eye Consultants, what we call the Mexel approach. We first apply proparacaine to the treatment eye. Then the eye is prepped with a 5% povidone iodine solution. And then the KeraFlow sponge is soaked with 3 to 4 drops of proparacaine and is attached to a syringe that has compounded riboflavin at a 0.6% solution, and the tubing is primed with that solution. The KeraFlow is then placed onto the treatment eye by the provider, and the sponge that's attached to a rigid scleral shell and attached to that tubing can then be used to gently remove the mucin layer of the tear film to aid in the riboflavin penetration. This is done first by placing the KeraFlow underneath the upper eyelid, usually gently retropulsing the globe to pull the lower eyelid over the base of the device, and then with the patient looking up, the device is moved slightly up and down. With the patient looking down, again with closed lids, it's moved slightly up and down. And then the similar process is used when the patient is looking to the left, moving the device left and right, and then when the patient is looking to the right, moving it back and forth, left and right. And this just gently removes maybe about a half of the superficial epithelium layer, as well as any mucin that might reduce penetration of the riboflavin. The technician then slowly pushes the riboflavin solution over about a 20-minute period, and this can load the cornea. During that time frame, it's important that the technician monitor to make sure that the patient appears to be looking relatively straight ahead, again with their eyelids closed. We found that this is very comfortable for the patient and easy for the technician, and they can save a little bit of the solution in the tubing. Maybe not necessarily any has to be left in the syringe, but they can save a little bit in the tubing by closing the stopcock on the KeraFlow device before removing the KeraFlow device from the eye for the physician examination. And that way, if there is a need for additional loading, then you have the approximately 1 cc of fluid that's left in the tubing for later delivery. The KeraFlow then is removed from the eye, and we place a drop of the Photrexa solution onto the cornea. The physician then comes in and examines the patient at the slit lamp to make sure that there's good corneal saturation and a presence of yellow flare in the anterior chamber. We'll typically do this still with the patient laying down and utilizing a portable slit lamp so the patient doesn't have to necessarily get up again before the technician does the light delivery. Again, if the yellow flare is not present, then we can do additional soaking of BAK riboflavin from the solution or additional soaking with the Photrexa solution, which you still have quite a bit left of through delivery through the KeraFlow once again. We also measure pachymetry at this point in time. We found that the pachymetry typically will stay very neutral because of the fact that the eyelids have been closed during this loading of the riboflavin solution. The technician then aligns the patient with a lid speculum and the Avedro light, and the eye is treated with light for 30 minutes, very similar to what's done in the Avedro protocol. We'll typically use a little bit of fractionation of the light to allow increased oxygen absorption, but we haven't been utilizing high oxygen saturations or concentrations or any supplemental oxygen, although this may be important in some of the future protocols for collagen crosslinking. We'll then instill an artificial tear, dependent a little bit upon the corneal thickness, typically about every 10 minutes or so. A little bit longer if the cornea is, or a little bit more space in between the application of artificial tears if the cornea is fairly thick, and a little bit more frequent if the cornea is fairly thin. The goal is to not overhydrate the cornea, and then we also do not apply additional riboflavin because the soaking tends to be very complete, and that riboflavin on the surface of the cornea may potentially block the light from entering the main component of the stroma. Here's the KeraFlow lens that, again, is distributed by ESI Incorporated, which is a Minneapolis or Plymouth, Minnesota company. You can see that there's a sponge that's attached to a rigid scleral shell that's then attached to tubing. There's either a stopcock or a roller ball that's in place upon the tubing that can be used to stop the flow if the syringe needs to be changed for additional loading, or if you want to utilize the solution that remains in the tubing. And typically the technician will just set the tubing down on their chest while they're waiting 30 to 60 seconds before another small pulse of the fluid solution. What's important is to make sure that the sponge at the delivery site remains saturated with riboflavin that's of approximately the same concentration that you're trying to deliver. It will get slightly diluted by the patient's tears, although they don't tear an enormous amount during this procedure, but the goal is to have that concentration reside over the whole cornea for the entire duration of the procedure. So every 30 to 60 seconds, they apply just a tiny little bit from the syringe by advancing that syringe during the treatment process. So the purpose of this study was to evaluate the KeraFlow device during loading, during the epithelium-on cross-linking process, and we wanted to look at whether we were able to thoroughly develop riboflavin corneal saturation in this shortened amount of time that we looked at 20 minutes basically rather than the typical 30-minute process. And as precursor to this, we looked at a variety of different times with epithelium off cross-linking by delivering it through the KeraFlow device with the epithelium off, fully off. The device can typically load the cornea within 5 to 10 minutes. And we did this by slowly shortening the delivery time on sequential patients and looking to see when we felt comfortable with the amount of saturation. Again, remembering that if we didn't have adequate saturation, we could continue the delivery for a longer period of time. And so again, with epithelium off, we had found that it's approximately 10 minutes where you have at least over 90% of the patients are fully saturated. In this study, though, we were looking at leaving the vast majority of the epithelium on. And so again, we utilized approximately 20 minutes as the time to evaluate that saturation. And this was done by slowly reducing that time frame. When we've utilized less concentrated solutions of riboflavin, then we found that those times are in the 30 to 40 minute frame to deliver solution to obtain saturation similar to a drop format with epithelium off, and again, approximately 30 to 40 minutes if the epithelium's on using a more dilute solution. But again, this is a 0.6% solution that was utilized in this trial. And we utilized a retrospective analysis, and this is patients that were treated over the year period between June of 2017 and June of 18 that represented 233 eyes from 140 patients. And what we utilized was the primary time to adequate saturation, and then also saturation grading, and then also whether a epithelial defect was present on postoperative day 1 or on day 0. And those of you that have done cross-linking before, if you've done epithelium on protocols, in some patients over the apex of the cornea, if they're very steep, even when you're very careful with the epithelium, it can erode over the apex of the cornea. So we anticipated that some patients would have an epithelial defect, but the goal was to try to minimize the size and extent of any epithelial defect. We utilized patients that were 18 years or older, and then again, if they didn't have the standard protocol as I've described previously. The mean time to adequate saturation was 20.5 minutes. Again, we evaluated that saturation starting at various different times at approximately 15 minutes, and some of those patients did require additional loading time. Saturation was graded specifically for 55 of the eyes, and all of them achieved on a 4-point scale at least 3+ loading over the entire cornea. Again, this was at the mean of 20.5 minutes. We did have 22% of the treated eyes that had epithelial defects, though most of these were small epithelial defects, again, typically over the apex of a very steep cornea that had keratoconus. So in conclusion, the KeraFlow device provided a very effective as well as safe in this trial and efficient delivery of riboflavin. This was in an epithelium on protocol, or a superficial epithelium off, as we term it, protocol, because there is some epithelium that's removed in this group of patients, although these epithelial defects tend to heal very quickly because the epithelial disruption is small. We still utilize contact lenses and frequent lubricating devices, a little antibiotic and steroid in this group of patients, because without this, that ultraviolet keratitis that occurs from the cross-linking process still is quite uncomfortable, yet the chances of infection are less when the epithelial defects are smaller, or if there is only a heavy punctate keratitis that occurs as opposed to a true epithelial defect. Again, scarring appears to be less in the epithelium on type protocols that have been reported elsewhere, and especially when compared to epithelium on. And we've had great efficacy of the cross-linking procedure in this group of patients. As these patients have been followed further since this study, We've had no one that's gone on to develop progressive ectasia, although the group of patients is small. And we also do other things such as counsel about eye rubbing, face sleeping, to try to also minimize other risk factors for progression of the keratoconus disease. Here are some references on collagen crosslinking and transepithelial crosslinking that were presented as part of this poster. Again, this is data that was presented at the ASCRS in 2019 as a poster from Minnesota Eye Consultants. Again, David Harden from Minnesota describing this information. Thank you for the time that you've taken to review this information and listen to our presentation.